This morning, I'm trying to talk about schistosomiasis. So I've taken some twist. I want to focus on one area which is quite new in schistosomiasis. So I'm looking at bacterial translocation in hepatosplenic schistosomiasis. These are some of the new insights that we have seen. So I'll start with the burden of schistosomiasis. As you may see there, it's quite prevalent, especially in Africa. Okay, you can see there are many species of schistosomiasis, but my focus today my focus actually is on, this morning is on schistosomiasis, Schistosoma mansoni. There are many species. So if you see the blue color, this is where the Schistosoma mansoni is so prevalent, as well as if you see in South America, it's quite prevalent. How about my country, Zambia? It's quite a common disease entity, and this is the commonest cause of portal hypertension, even in our setup. Most of the parts in Zambia, especially the western part, are quite endemic for cysto. We see a lot of cysto in our area, and zero prevalence can reach as high as 88% in some districts, especially in the western part of the country. Right, just to maybe recap on the life cycle. I don't want to go into details because I might bore you, but the importance of this slide is just to show you that transmission of schistosomiasis occurs as a result of repeated contact with water bodies that are potentially infected with schistosomiasis. So you get this infection through the skin, Cercaria, and then the cycle moves on, and then you get the schistosomes and all that affecting the liver, and then you also get eggs deposited, and then they cause inflammation, and then you end up with portal hypertension. Now, most people are actually affected with infected with Schistosoma mansoni, but fortunately, just a handful of people get actually severe form of disease. About 5 to 10% will get severe form, and it will present with, sometimes may present with hepatosplenomegaly, as you can see there. Sometimes the spleen can be as huge as that, okay? Some patients will actually present with ascites, although it's not a common presentation, but we have seen in our setup that patients do present with ascites, especially when the disease is quite advanced. For diagnosis, actually, it's quite characteristic. If you look at the abdominal ultrasound, you can see periportal fibrosis, quite prevalent, quite clear, like that. So this is one of the modalities of making a diagnosis for hepatosplenic schistosomiasis. Right, so what are the factors that are associated with severe periportal fibrosis in patients that are affected with Schistosoma mansoni? There are quite a number. One of them is intensity and duration of infection. So patients that are keep getting repeated infection, and they have high burden of egg deposition and things like that, they end up having some severe form of periportal fibrosis. The other thing is concurrent infection. And concurrent infection here means if patients are co-infected, for example, with Hep B, Hep C, they tend to get severe form of disease. Or if patients are infected with multiple number of species, also this does contribute to severe form of periportal fibrosis. Host nutritional status. Those patients that are whose nutritional status is quite poor, they tend to get severe form of disease. Genetics do play a role, and this results into unregulated expression of immune responses, and then patients tend to get a severe form of disease. Right, so what's the commonest cause of morbidity and mortality? So the commonest cause of mortality and morbidity is portal hypertension. So these patients, because of periportal fibrosis, they end up with increased portal pressure. And this then results in varices. And we see a lot of patients now coming into our hospitals with varices. Sometimes they can be huge, okay? Some present with what we call protogastropathy. So this is the commonest cause, cause of admission in our setup. Of course, some patients are admitted because of anemia and things like that. The anemia comes in because of they have massive splenomegaly and they tend to have hypersplenism, and then they will present with a pancytopenia because of pooling in the spleen. Some will present because they have this repeated variceal bleeding. So this is the commonest cause of morbidity and mortality. Now, I had talked about the new insights. Previously, we didn't actually think that Schistosomal liver disease could actually present with bacterial translocation. But now, over the few years, we have noticed that this could be true. You see, Schistosomal liver disease and cirrhosis are actually similar disease entities. But we know that bacterial translocation actually does drive portal hypertension in patients with cirrhosis. And how does it do that? Because of bacterial translocation, there is an increase in splanchnic vasodilatation in splanchnic vessels, and that leads to increased blood flow. And then consequently, this leads to increased portal hypertension. So that's what occurs in cirrhosis. So, as I said earlier on, these two disease entities are similar. The main difference between cysto-related portal hypertension and cirrhosis is that in cysto, the liver parenchyma is basically normal because the disease is periportal, like I showed you in the earlier slides. Whereas in cirrhosis, the liver parenchyma is affected, and that's the main difference. So we had not studied bacterial translocation in cysto, and we thought this actually could be occurring in cysto as well. Yeah, this slide is just shows just to emphasize that the bacterial translocation does actually lead to increase in portal hypertension. So in this slide, this is a study that was done in Russia, and they wanted to use rifaximin. And by the way, rifaximin is a drug that is non-absorbable. So they gave the drug for about 4 weeks to patients with cirrhosis, and they noticed that at the end of 4 weeks, there was reduction in portal pressure, meaning that bacterial translocation does actually lead to increased portal hypertension. Now, then is there any similar association of bacterial translocation in cysto as well? So in the past few years, we had actually embarked on the journey to see if there is at all an association of bacterial translocation with cysto. Now, a few years ago, we published this paper, which actually pointed to the fact that bacterial translocation may be playing a part in schistosomiasis. So this was a case control study where we had patients with cysto diagnosed on serology as well as ultrasound. So the inclusion criteria were patient with hematemesis, okay, periportal fibrosis as evident on ultrasound, and those that actually came in with a splenomegaly. So patients with HIV, hepatitis B, hepatitis C were actually excluded from the study. So what did we then find out in this study? Yeah, so this is just a demographic baseline clinical data. I just want to point out that what was evident that most of the parameters were actually raised in cases as compared to controls. But ALT, if you look at that, there was no difference between the cases and the controls, which just confirms that in most cases, cysto, the liver function is actually normal. Right, so these are some of the markers that we saw. The first one here is lipopolysaccharide binding protein. We see here that in patients it was much elevated as compared to controls. And hyaluronic acid, by the way, lipopolysaccharide binding protein is a surrogate marker for bacterial translocation. Hyaluronic acid, which is a fibrotic marker, was as well increased in cases as compared to controls, and so was laminin. Laminin is a fibrotic marker as well. The other inflammatory markers like soluble or CD114, soluble CD14 and soluble CD163, which is a marker of Kupffer activation, were actually increased. But look at CRP. CRP was quite comparable in cases and controls. And we all know that CRP is an acute reactant molecule. So meaning that these patients have chronic infection, and and they didn't have an acute sort of infection. And this confirms that, well, these patients have chronic infection, but not acute infection. So when we try to correlate some of the markers of bacterial translocation, fibrotic markers, and inflammatory markers, they are linearly correlated and quite significantly, which means that bacterial translocation is driving actually systemic inflammation in these patients, even though these patients have chronic disease. We've again tried to re-emphasize this point. So we did another study where we looked at two different groups: patients with environmental enteropathy, patients with cysto, and the controls. We wanted again to see if the markers were different in these patients. Again, here we see that the markers of translocation, like 16S RNA, were actually increased in cysto patients as compared to controls, but they were more increased in patients with environmental enteropathy. And so were the TLR ligands. They were also as well increased in patients with cysto as compared to controls. This also was similar with the interleukin 10, interleukin 4, and interleukin 2. They were all elevated in patients with cysto-related portal hypertension as compared to controls. Then what? Would we then conclude that yes, bacterial translocation does occur in Schistosomiasis. So then we went on to do a clinical trial to just see if at all, yes, the translocation is occurring from the gut. So we designed a study using rifaximin. This was a clinical study, clinical trial using rifaximin. Like I said, rifaximin is a non-absorbable antibiotic, meaning we wanted to reduce the bacterial load in the gut and see if these markers that we saw in the case control study, in the other two studies, were actually going to go down. So this was a clinical trial which ran for about 42 days. So we actually recruited 85 patients and randomized 44 to rifaximin with standard care and 41 to just standard care. I must quickly say this was an open label clinical trial and the patients were followed up for 42 days. The standard care actually included propranolol. As you know, propranolol is a very, very cardinal drug that is we use to reduce portal hypertension in patients with cysto-related portal hypertension. And the other drug that we gave was prosequantil to all our patients. So at the end point where the primary endpoints were reduction in BT markers and reduction in inflammatory markers as well as reduction in fibrotic markers. We also wanted to see if there was a beta blockade at the end of 42 days and if at all there were reduced episodes of hematemesis in these patients. So this is just a trial flowchart. So at the end of it all, in the rifaximin arm, about 90% of patients completed the study, and 36% in the non-rifaximin arm actually went on to complete the study. Right, so if you look at the baseline, most of the data was actually comparable between the rifaximin group and the non-rifaximin group. So after 42 days, what happened? We noted that there was reduction actually in a pulse rate in these patients, okay? And there was an increase actually in hemoglobin levels. However, in full blood count indices like white cell count, platelet count, there was no difference at the end of 42 days. So we actually again analyzed the markers of translocation, and the marker of translocation, which is quite direct, is 16S RNA, you know, which we analyzed, and we noted that after 42 days there was reduction, okay, in the rifaximin arm, okay, meaning that rifaximin did reduce the bacterial load in the gut in these patients over 42 days, and that was quite significant. This also was similar in terms of some inflammatory markers, and we chose some of these markers because we couldn't repeat all the markers that we had seen in our previous studies. Soluble CD1 was actually reduced in the rifaximin group as compared to the non-rifaximin group. Again, by reducing the bacterial load in the gut, by reducing translocation, we noted that even the inflammatory markers actually went down. And this also occurred with tumor necrosis factor receptor 1. But there wasn't any change actually in the fibrotic markers. And our postulation was that, well, the disease is already established, so to reduce the fibrotic markers, it may not be realistic. So now, so how do I summarize? So now this is a new insight that we are seeing, that bacterial translocation is part of the pathophysiology of hepatosplenic schistosomiasis, and this actually induces systemic immune activation in patients with cysto, even though this is a chronic disease. We noted that rifaximin reduced 16 sRNA copies and inflammatory markers in patients with schistosomiasis. Now, there is need actually to further explore if rifaximin gives a clinical benefit, especially in acute variceal bleeding. I must quickly say that most of the patients were patients who were stable and just came to our hospital because of previous variceal bleeding. Although there is a bit of some clinical improvement in our patients, it's hard to actually say rifaximin did help. As in all our patients after 42 days, we couldn't see any patients who presented again with variceal bleeding. And actually we also noted that hemoglobin levels went up in these patients who were on rifaximin. The follow-up was too short to actually conclude that yes, rifaximin really did. But one thing we noted is that it reduced the markers of inflammation as well as markers of bacterial translocation. So could we say now that patients with cysto could benefit from antibiotics? As you may know, a patient with cirrhosis who presents with variceal bleeding, actually antibiotics the standard care. So could we extrapolate and start giving patients antibiotics, especially those that have acute variceal bleeding, now that we know that there is association of bacterial translocation occurring in this patient? Thank you so much.